As you've just heard from Dr. Chapman, um, I am a local surgeon, but I've created a foundation to do education in neurosurgery in South Asia, particularly in Nepal, and then secondarily in the Maldives. And I'll give a little story about how that all happened. And then the arthroplasty side of it is basically the natural progress of bringing new technologies step by step into that part of the world. From when I first went there in the 70s, I started climbing and trekking. That's what really made me fall in love with, particularly Nepal. Obviously, not the Maldives, but the Maldives story stemmed from Nepal. So trekking, climbing in Nepal, I wanted to give back to the people. So about 10 years ago, I signed up with the Foundation for International Education in Neurosurgery. Merwin Bagan was the head of that organization, and he basically introduced me and got me positioned to teach in Kathmandu, where he had set up the first neurosurgery program in the country and taught the first residents. And it's been basically one or two trips every year for me going back. When I first went there, it was to do routine neurosurgery at the level of the country, but with maybe new implants being brought in to make it better than using what they were doing previously to my arriving there. And an example was that when a fusion in the lumbar spine was necessary, the family would go out under the instruction of the surgeon and find some steel rods in the local market, and then get some steel wires at the local hardware store, bring it to the surgeon in the hospital. He would bend the rods, cut the rods, sterilize everything, and that would become the fusion construct. Well, fast forward, I started bringing in, you name it, pedicle screws, rods, cages, et cetera, et cetera. And then it was pretty clear that they were ready to start doing arthroplasties. The story of doing arthroplasties in this part of the world is what I'll show you here. But I'm going to give you a little background to the kind of area we're dealing with. So next slide, please. You can see Nepal and the Maldives, they're fairly close to each other, but a world apart. So next slide. Nepal is the country just north of India, south of China, 8 of the 10 world's tallest peaks, including Everest, average altitude 10,000 feet, literacy rate 66%, average life expectancy 70, GDP per capita $1,000 a year. It's a low-income country, and I'm going to tell the story about bringing arthroplasties to low and middle-income countries. And why that's important, we'll come to as we go through this presentation. Let's go to the next slide, please. The Maldives, in contrast, 2,000 islands. Average altitude instead of 10,000 feet is 4 feet above sea level. Population 540,000. Literacy rate almost 100%. Life expectancy close to 80. GDP per capita 7,500. Maldives is a middle to higher income country in contrast to Nepal. Interesting thing about the Maldives, from the point of view of neurosurgery, spine surgery, they had no one doing any spine surgery whatsoever until there was one Maldivian citizen who was sent to Nepal for training in neurosurgery. Next slide, please. At this university teaching hospital where Merwin Bagan set up the first residency program, which is where I worked, big government hospital, 700 beds, thousands of outpatient visits, residency program. They took the Maldivian citizen under the situation where he promised to go back to the Maldives and become the first Maldivian neurosurgeon, because the 500 plus thousand people in the Maldives had nobody to do brain or spine surgery for that matter. And they had to leave the country, go to India, China, other places, Sri Lanka, for care. So Ali Niaf was the first resident that was trained in neurosurgery and went back to the Maldives. Next slide. And there he is standing next to me in the white outfit. We ended up inviting him back here to the Seattle area. He spent time with me and in my practice after he finished the residency. Then he went to the Maldives, set up shop. And the hardest thing was getting the confidence of the Maldivian citizens. So all he did at first was carpal tunnel surgeries. And nobody wanted to go to him for brain or spine because it was so new, they didn't know him, and they continued to go out of the country. So he invited me to go there, and I was already going to Nepal once or twice a year, as I mentioned, sometimes even 3 times a year. So I started adding the Maldives, and we started doing meetings and live surgeries that were broadcast on the internet and through Facebook, etc., so that Maldivian citizens could see Ali and myself doing now progressively sophisticated surgeries. It created a confidence level for him that really created the beginning of a really solid practice. And just like in the Nepal arena, all arthroplasties were later. We started with straightforward spine surgeries of various types. And then once the fusions and decompressions, MIS included, were mastered and were routine, we brought arthroplasties in. Next slide, please. This is the hospital where Ali works. It's very different from the hospital in Nepal, which, as I showed you, was the government hospital. This is a private hospital. It's a more middle income sort of place where there's a lot of equipment, a lot of staff, and very solid surgical group. And Ali was able to grow very quickly because of the confidence of the people in his practice and the support of a private hospital system to allow a young neurosurgeon to really get what he needed to do 21st century neurosurgery. Next slide, please. Operating room in Nepal is very nice, but as you can see, older, different sorts of equipment than you see in the operating room in the Maldives. Next slide, please. Maldives is state of the art. It looks just like an operating room at Swedish or one of the Franciscan hospitals. And they have adequate budget so that whatever equipment is necessary, they can get it. Next slide. So let's go to the first arthroplasty in Nepal. This was ProDisc C, as you can see. Perfect case, nice big soft disc herniation. Patient was counseled that we can either do this anteriorly with fusion or artificial disc, or we could do a posterior laminopharaminotomy microdiscectomy without a fusion. And the patient wanted the artificial disc. Obviously, as a donation, it made it easier for the patient to choose that, because given the cost of an artificial disc, it would have been prohibitive if the patient had to pay for the implants. Because the way it works in Nepal, if you're going to have a spine surgery, the government gives you the bed in the hospital. It might cost $1 a day. It gives you the care, but implants have to be covered out of pocket by the patient. And you can imagine the different costs. And these were costs that we see in the United States, which are in the $2,000 up to $5,000 range per an implant. It would have been just impossible for a patient in Nepal to have this surgery. But thanks to the company that donated this ProDisc C, we were able to do the first cervical arthroplasty in Nepal 5 years ago. Next slide, please. The first cervical arthroplasty in the Maldives I actually did the prior year. And this story is a great story because Ali told me he's going to get just the perfect patient for me, but he wouldn't tell me anything about the patient. I had to just trust him, fly, halfway around the world and be ready to do a surgery on a patient. When I got there, he said, well, you were worried, but the patient is my anesthesiologist. She has not been able to do anesthesia for me for a month because she has severe radiculopathy every time she flexes her neck because of a disc herniation. And she heard that you were coming and she wanted to have the surgery by you with the first cervical arthroplasty in the Maldives. She did not want to leave the country for an arthroplasty. She did not want to stay in the country for Ali to do a fusion. So I said, great case. We did her, and she was back to work doing his anesthesia in 2 weeks, and forever grateful for restoring function. She has no symptoms. You all know the great results we get with these arthroplasties. So this was a memorable case. It was absolutely the perfect first case in the Maldives. This was broadcast to the population and very well received. Next slide, please. Lumbar arthroplasty. We did the first lumbar arthroplasty in the Maldives the year after the first cervical arthroplasty. And again, Ali picked the perfect patient. It was a semi-professional soccer player who had severe low back pain. You can see his MRI, the black disc, annular tear, severe pain. So we, again, offered him anterior lumbar interbody fusion ALIF versus arthroplasty versus TLIF, and he selected arthroplasty. We did the ProDisc L. I brought my approach surgeon over. We taught the approach to some of their general surgeons. I taught this procedure to Ali, who had actually done a few of them with me here in Seattle, Tacoma, a few years earlier when he came over to visit. And again, perfect result. If you can go to the next slide, please, Corey. I saw him for follow-up a year later. He came in just to say hello, and he gave me this lovely thank you note. And we got flexion extension films. He did absolutely great, very full of gratitude, just a great follow-up. So now we have the first cervical arthroplasty, the first lumbar arthroplasty in the Maldives. And we tried to do the first lumbar arthroplasty in Nepal a couple times, but the team over there just could not find just the right case. So we're trying again, and we're going next month again, and we've got 2 cases lined up. We're bringing an approach surgeon from the Mayo Clinic who's going to help teach the approach. Previously, I had brought my approach surgeon, just like I did to the Maldives, to Nepal to teach, but they just could not find the right case for lumbar arthroplasty. But this year, we're not giving up. They really want to learn the arthroplasty procedure and do live surgery. So we'll do 1 or 2 in about 5 weeks from now in Kathmandu. Next slide, please. So what are the advantages of this? I mentioned the cost was a disadvantage, and the advantages in lower middle income countries over fusion are very obvious, very logical. Quicker return to work, and work is really critical in these places. People don't have disability insurance. They don't work, they don't get paid, their family doesn't have food. Everything you do is in the back of your mind something that has to get them back to being a productive member of society and to be able to bring money into the home. So that's the immediate goal. The longer term goal is not to have reoperations because of, let's say, failed fusions or something on that level, or adjacent segment degeneration, which, as we all know, is less frequent after you do an arthroplasty than an arthrodesis. So you're preventing additional surgeries as reops or adjacent segment operations, extending a fusion, et cetera. And that saves these patients in countries where being out of work, having to go through yet another operation, you want to avoid that at all costs. And then a lot of their jobs are major physically active jobs, and they do not need any limitation in the range of movements to be safe. They need to have full range of movements and be very agile in their jobs. A lot of them are field workers, farmers. They climb trees. They climb cliffs as bee hunters. A lot of them are workers in expeditions and treks, carrying lots of weight on their backs and actually with tump lines on their heads. So everything you do, you have to think about getting them back to work and not having them come back to the hospital for some collateral issue from what you did that you could have avoided by doing an arthroplasty. And the next slide just brings home the point that the only disadvantage of arthroplasty over fusion is the cost. So there right now aren't any that I know of arthroplasty devices made in the local countries that produce implants for fusions, particularly cages included, screws, plates, rods. Particularly India, as you all know, they have a low cost production line of good quality spinal implants. And right now, we have to bring donated implants from the US to do these surgeries in those countries. So it would be really great if either one of the big producers of implants of the arthroplasty variety that has a base in South Asia recognizes the potential market that they could garner by producing low-cost, high-quality arthroplasty devices for cervical and lumbar surgeries for use in South Asia. And next slide, please. On that note, I'll it's a short, quick, very simple message. I show you a picture of classic scenery in the Himalayas. That's Mount Everest in the distance. And the Maldives, absolutely gorgeous tropical islands with incredible fish for those of you who like to dive or snorkel. As Dr. Chapman and Dr. Allman know, I bring 2 new spine surgeons with me every time we go. So if this whets your appetite, let me know, because we're really excited about bringing new people to help teach. Our mission is teaching, not just doing lots of surgeries, but teaching new procedures every time we go. So let me know if this excites you. And on that note, I'll say thank you very much for your attention. And I don't know if there's any time for questions or if there are any questions, but I'd be happy to answer anything that comes up. Thank you.
Very inspirational, and congratulations on your work, Richard. Any questions or comments? Todd, are you going to go? You went, right?
I already went. Yeah.
Okay, microphone's yours.
So just as a plug for helping Richard in future endeavors, it is a phenomenal trip that you will learn as much from as you will teach. So it is an absolutely great thing to do. One of the things that I think is kind of interesting when I was there, at least, is to, and I think you kind of alluded to this in the Maldives, to kind of get a feel for the local population's feel for spine surgery? Is it worth the risk? Do I live with my disability? How have your impressions of that sort of changed over the years as you've gone back there?
Yeah, that's a great question, Todd. And thank you for your excellent work when you joined us. And we certainly would love to have you back. And Scott, I've invited you every year, so you're up next, you and Jens. The population is very stoic, and they quite often don't come in for attention just for pain, like the average American patient would come in saying, I hurt. They come in when they're neurologically impaired or having so much pain they can't even get out of bed and can't work. You don't see people who are ambulatory, still working, able to get by with the level of pain they're having. They're very averse to doing anything unless they're really, really impaired, to the point where a lot of the patients we see, and I'll talk about Nepal first, a lot of the patients we see are brought in on the backs of a relative or a friend, literally being carried from a village 9 days away into Kathmandu. They can't walk. That's it. They can't get in any other way. There's no public transportation that'll get them in from the mountains. And they are non-functional. They have either neurological impairment or such severe pain they cannot function. So that's when they look for medical attention. The ones who are living with a lesser degree of pain, you just never see. The clinics don't have people with minor complaints. Clinics have people who are close to end stage pathology, end stage symptomatology. Now, Maldives, a little different. Socioeconomics are a little different. Smaller population, way more exposed now to what is possible for them based on the excellent marketing and media coverage that has gone on by this private hospital with Ali's practice in our yearly meetings and yearly new surgery updates that really have reached out to all 550,000, now 600,000 Maldivians. They know what's available, and they like this technology. They don't want to travel. They'll come in for a consult, and they'll more likely be more similar to what we see in a higher income country with patients that have not end-stage pathology, not horrible neurological compromise, but just lesser pain, and they want to know what can be done. They're very interested in the MIS surgeries that we've done. They more often go for an MIS procedure than a maximal procedure. So we actually have done quite a number of MIS T-lifts for spondylolisthesis in the Maldives because the patients like that concept of the MIS approach. They don't necessarily like big open surgeries, and just to have done some A-lifts and the lumbar arthroplasties was a big step there, but I think we'll see more of those there because they've seen the patients do well, and all this is very public.
Richard, have their access surgeons stepped up so he's getting good access from local guys now?
That's a really good question. That's Jack?
Yeah, it is.
Yeah. Hi,
Thanks.
Jack. Thanks for the question. That's always a big issue. As Todd will tell you, he did the approach for us in Nepal and in the Maldives. We've trained a couple people, but we need to get a routine 1 or 2 person support from either vascular or general that are committed to being the approach surgeons every single time, so they get really good, really safe, really fast. And that is on the way to happening, but hasn't happened. I can say they're very interested in it. And the key thing is they're not the roadblock. It's really how many cases Ali and his group could get in the door. They're still more enamored with the MIS posterior approaches, and we just have to give it time. Something we can't push. But once they get the idea, and I'm talking more lumbar here, obviously. There'll be more arthroplasties. There'll be one or two approach surgeons. The anterior approach to the spine, cervically, obviously, is a no-brainer for most spine surgeons to do arthroplasties and fusions. That's not an issue. We're just talking about lumbar.
Yeah, I mean, the sub-thread of what you told us, I'm just fascinated by how you were able to bring credibility to his practice by doing the things you did. Very admirable, and I think you did more for that patient population than you're giving yourself credit for, because otherwise he could have been floundering for a long time before they developed trust. So that was a wonderful thing you did.
Well, thank you for the nice comment. I appreciate that. Thank you.
Richard, this is Rick. So when you go over there, how long do you spend and how many cases are you operating on?
It's between 1 and 3 weeks, and it just depends what's going on. We have a spine week where we really do most teaching. We do 2 or 3 surgeries every day, and then we have one of the days where it's just maybe 14 or 15 lectures. And then we have dinner lectures with, like one of the people that I bring with me will take out 3 or so of the fellows, the residents or the junior faculty, and do kind of more one-on-ones, so to speak. So that's a real hot and heavy week. And then we also go over for longer periods of time in the spring, and it's not quite as much condensed. It's more spread out. So we'll do more surgeries over a longer period of time, but not as concentrated as during Spine Week, which is in the fall of every year.
And do you alternate going to Nepal and the Maldives, or do you do them all in one big trip?
Well, I used to do them individually. Then I said, well, they're so close to each other. Let's do them back to back. And that was a killer. Because it used to be you can fly from Nepal to the Maldives or vice versa pretty easily. Well, that's no longer the case. And going through India is difficult, to say the least. Going through Sri Lanka and then India is difficult, to say the least. And now the best way really requires that you fly back to the Middle East through, let's say Doha, by Qatar Air, QATAR Qatar. And so you can imagine you have to fly from the Maldives back to Qatar, wait number of hours, 4, 5, 6 hours, and then fly back to Nepal or vice versa. It's a nightmare. So we've now created 2 separate trips again. And then, that's an issue because these are long trips that require basically a day and a half to 2 days of travel to get there, and a day return. And you make up some time coming back, depending on which way you go. I can give you details. It's little OCD on my part, but I believe it's best to go west. Go west, young man, is the old phrase. You have less upset to your circadian rhythm, less jet lag. So actually the best way is to go like to Singapore, then to either Nepal or the Maldives, and then to the other country, maybe, or a separate trip, and go around the world to come back. So
right now, are you going to each facility once a year?
Maldives is once a year. Nepal will be 3 times in 6 months, which is the most ever. Usually it's no more than twice a year.
Okay, Scott is checking his calendar. He'll let you know when he's going.
Man, Scott, you're signed up.
Thank you very much, Richard. It's been a pleasure. We appreciate your joining us and for all your efforts. Thanks.
Thank you very much for having me.